you. Let me just start. Perfect. So I just want to say welcome. Thank you so much for joining us. I know that you're having a hectic day today. I'm sorry about that. And if you just want to tell us a little bit about you, your professional achievements, your career, how did you get into hip surgery and stuff like that? We just want to get to know you a little bit better.
It's nice to get to know you. So my name's Dr Kraushaar. I'm an orthopedic surgeon who grew up in Rockland County, and I enjoy living here and working in the place I grew up. I went to Colgate University and then Albert Einstein College of Medicine, and I trained in the Bronx as well as in New York City and even at Georgetown for orthopedics and sports medicine. My practice is divided between sports medicine and joint replacement, and I do a lot of joint replacement here at perform our hip and knee replacements, and I have been doing them for about almost 25 years now. The type of procedures we do at Nyack Hospital and that I do at Nyack Hospital include total knee replacements, partial knee replacements, total hip replacements, and partial hip replacements, depending on what a person needs. And when I do hip replacements, I do two different approaches, which you may hear about. One is called the posterior approach, and the other is the anterior approach to the hip replacement, and we will get into a discussion about that later. I have a practice in Nanuet, and we see patients in the office and then take care of them here at Montefiore Nyack.
Excellent. Thank you so much. So for the sake of our topic today, which is the hip replacement, why don't you let us know a little bit more about that? Now, you've mentioned a few things that are definitely new to me, so like the total and partial hip replacement. So what will be the difference between the two?
Well, partial hip replacements are called hemiarthroplasties, and those are usually performed when a person breaks their hip. And if they're elderly. So if a person breaks their hip, we don't necessarily have to do a total hip replacement. As a matter of fact, there are many people who don't need any form of hip replacement, but with certain types of fracture patterns or broken hips, a replacement of the head of the femur, that's the upper part of the hip bone, can be performed. And so what that is it's a replacement of just the ball, but not the socket of the joint. And that's commonly performed in an elderly person who's frail and really doesn't need a total hip replacement in order to just get back to where they were before they broke their hip. Otherwise, resurfacing of hips and partial hip replacements are reserved for some very narrow circumstances, and the rest of the patients are going to be about total hip replacements, which is really the focus of the rest of this conversation.
Okay. So do you wanna tell us about the total hip replacement?
Sure. I will provide separately a slideshow regarding the actual images. I'm in between surgeries right now, so I can't really show that, but I will get that to you separately. And what it is when a person has arthritis in their hip, there's not much you can do for arthritis in the hip. When the cartilage is worn off of the ball and the socket and the bones are grinding against each other, people can feel that. They can feel the swelling in the joint, which is like a dull toothache. And when they try to sleep, they sometimes are even woken by it. A common symptom will be difficulty tying your own shoes because you can't rotate your own hip far enough to reach the shoe and put it on. The person who's lost function, who can't walk a city block or two without feeling that their hip is bothering them. Someone who complains every day that their hip is their main problem, and who is otherwise generally healthy. That's the kind of patient we end up having a good discussion about hip replacement with. That's the kind of person who benefits very well from a total hip replacement when it's performed at the right time in the right person. We try not to put total hip replacements in very young people in their 30s or 40s. We try to at least be in your late 50s or beyond. And the oldest person I've put a hip replacement in was in her 90s. So sometimes we do that for people who really expect to be active for a while and are mostly limited by their hip itself. Of course, the partial hip replacements can be put a partial hip replacement in a 100-year-old because that's whose hip breaks. But for the elective procedure for arthritis, we try to be at least 65 if possible. Youngest person I put a hip replacement in was in their 30s, but that's somebody who had a degenerative hip from birth and never could go through life this way. And then another one was somebody in their early 40s who was a soldier who got hurt and needed an arthritic hip to be replaced. A total hip replacement involves going into the hip joint and removing the ball and then replacing it with a stem that goes into the femoral bone. That's the big thigh bone. And then also removing the cartilage in the socket and putting something called a cup or a socket inside, like a replacement socket. These things that I'm talking about are made of metal, and then there's something in between. So between the ball and the socket, there needs to be a surface that is smooth and durable. In the past, the socket would be made of metal, the ball would be made of metal, and you'd have a ball in socket, like a ball bearing inside a metal socket, and it would last a very long time. But the problem was that the ball and socket metal on metal combination resulted in metal filaments or fibers being released into the area and caused problems. So what we do instead is we put plastic in between the ball and socket, and that plastic is a sandwich. It's a metal ball, plastic in between, and then the socket is made of metal as well. And it turns out that the metal ball on the plastic lining socket, that's good. It's a good combination. Sometimes we'll use ceramic as well. So we can talk about the materials. Ceramic is a very durable material as well. It's more expensive, but it lasts a really long time. And in the youngest patients, it will be, instead of plastic, it'll be a ceramic liner that goes in between the two. The general technique involves creating a ball and a socket that are just the right size for the patient. And it has to be in just the right positioning. It has to be put in such a way that it will be stable and not have issues like instability after the procedure. What's nice, however, is that when this is put in properly and when a patient has the right surgery for the right reasons, this relieves their arthritic pain and usually for the rest of their life. I'm commonly asked how long a hip replacement lasts. It should last you the rest of your life. Of course, if you're 42 years old and you get a hip replacement and you live to 85 or 90, I can't really tell you that it's going to last that long. I probably won't be around that long to answer that question. But the quality of life during that first segment after the hip replacement is so much better than the arthritis that as long as it lasts 20 or 25 years, most people would be very happy to undergo surgery for that if they have that much pain before the procedure. The things that can go wrong during the procedure, for disclosure, I'm a human, you're a human, we're talking about artificial materials. There have even been allergies to the metals, to the materials. They're rare. Patients who have allergies to earrings and bracelets should definitely mention that, because if I do 100 procedures, maybe at most one would have an allergy, but I'd want to know ahead of time. It's extremely rare. Infection is very rare, about 1%. But if you're that one person, an infection can happen. It can be a problem. People who are at higher risk for infection should let their doctor know beforehand, and the doctor should be aware if you have out of control diabetes, immune issues, wound healing issues, and other medical problems that might make it too risky to perform a hip replacement. What other things can go wrong? When we take out the ball and then we put in a new one, when we take out the socket and we put in a new one, we don't take it out, but we grind it out. When we do that, we try to make the legs exactly the same length, but leg lengths can be a little bit different. As a matter of fact, if you have enough erosion coming into the procedure, you might actually not be aware, but your leg could be a 1/4 of an inch short. And when we put a prosthetic in and we make the leg the right length, you feel like it's a 1/4 inch long because we just put that much space in between. So some people have leg length inequality, but they usually get used to that very quickly and adjust to it. Of course, we want the leg length to be close, like within a centimeter or a 1.5 centimeters. We use metric, but sometimes we have to make it a little longer for stability, which brings me to my next issue about hip replacements. And that is that your own ball in your own socket is very stable. It's very rare to talk about a hip dislocation in a regular person. But when we put these prostheses in, the ball and socket is different. There's a different size, a different shape, a different geometry. And in order to get into the hip joint, one has to cut some ligaments to open up the space to look inside the ball and socket and put it back in place. Those ligaments are for stabilizing the hip joint. So on a rare occasion, there'll be an issue with dislocation. Fractures, we're doing bony work. And so if a person has osteoporosis, it's really bad, then they should think about that, and the surgeon should be aware of it, because we don't want to have a fracture. There's usually not a lot of bleeding in these cases. They're very well controlled. The anesthesia department does beautifully with the way that they manage pain during the procedure, and they have a medicine that helps to prevent bleeding as well. I mention it because it's pretty deep surgery. It's in the middle of the body. It's in the hip joint. So we do get good control of the bleeding, but sometimes we need to help a person afterwards. If I do 1 transfusion a year, it's a lot these days. We used to transfuse frequently. Now transfusions are very rare, but sometimes it happens. It's kind of rare. There's a new medicine out that helps to control bleeding, and this is usually a very controlled event. The sciatic nerve goes by the back of the hip, and if a person performs 200 or 300 hip replacements, one person might have a sciatic nerve issue. It's usually less than 1%, and usually if the nerve is stretched, it recovers by itself. But sometimes people do have a temporary issue. It's really, really rare. I'd say that between 95 and 98% of hip replacements are routine, without incident, do very well. And so if we're helping that many people out of 100, it's a very good feeling to perform hip replacements. Of all the operations in the United States that are considered successful, hip and knee replacements are among the highest in satisfaction. That's because you get the most benefit in the most people for the procedure compared to many other operations. It's almost always successful. The material that's inside your body is inert, it's neutral. You won't know it's there. You should not know it's there. It stays there for the rest of your life, and the metal should not have any reactions that will cause you problems later on. Pain. Well, it's hard to perform a procedure like this without going through the skin. But compared to knee replacements, hip replacements generally are much less painful. You can usually stand on them the same day. As a matter of fact, the trend is that we're sending people home either later the same day of the procedure or the next day. And that's happening more often, especially with new anesthetic techniques. The perioperative anesthesia, in other words, anesthesia around the time of the procedure, is a combination of medicines. And they don't all make you that confused. Anesthesiologists are now very good at nerve blocks. And nerve blocks help to control your pain so that when you recover in the recovery room, you're not in pain. You shouldn't be, because the nerve blocks are working. And those nerve blocks can last for hours and hours afterwards, and some into the next day. What that does is it helps you to get over the initial surgical event. And the farther away you get from the procedure, the better. The thigh and the hip have fewer nerve endings than the front of the knee. So in general, the skin is not that painful. There's a dull ache, but it doesn't stop you from getting out of bed. Pain is usually controlled after the procedure with oral medicines, and people don't require intravenous medicines very long. We give antibiotics during the procedure, and we give a couple of doses of antibiotics after the procedure, and we tend not to have you stay on antibiotics as long as there's no issues with the healing process. Same thing with pain medicines. We don't need an intravenous for it, which is why people can go home. Usually Percocet or similar type medicine is good enough for the first few days. And I get people onto over-the-counter medicines like Advil, Motrin, Aleve, Tylenol. Within a week after the procedure, people are very well controlled off of narcotics in most cases, which is nice because narcotics cause side effects like problems with digestion and dizziness and imbalance, and they can be addictive as well. I usually see a patient in the office within 10 days after the procedure, and that is to look at the wound and make sure everything's okay. Within 10 and 14 days after the procedure, the staples in the skin usually come out. I still use staples. Most doctors do. Some people use sutures under the skin without staples, and that's okay too. The staple removal process is nowhere near as painful as the surgery. And once they're out, the pinching around the incision feels better. People tend to move quickly. When I see a patient in my office after a hip replacement, the first visit is usually with a walker, although it's really common these days that they come with a cane. It's not uncommon for people to have a cane now. And then a month later, most people don't even need the cane. It's mostly to protect balance and to have something to lean on until you trust your leg again. Because usually these patients not only have post-operative symptoms that they're trying to get over, but before the surgery, they've really learned how to limp, and it's hard to unlearn your limp. So relying upon a cane or a walker is better than falling. And it's better to have something in your hand initially until you feel that you can handle it. I'd like to get into the two different types of surgical approach, because with one surgical approach, there are different requirements for protection after the procedure, and with the other one, there are not. There are two different approaches that surgeons make at Nyack Hospital for total hip replacement. There's the posterior approach and the anterior approach. The posterior approach is the one that the surgeons at your hospital have performed 1,000 times or more, maybe close to 2,000 times. That approach was part of our training and part of our initial practices, and until about 5 or 6 years ago, we always did the posterior approach. And whenever I'm doing a broken hip, which is many times a year, I'll use the posterior approach because it's tried and true. When doing the posterior approach, a patient is turned on their side so that the surgical side is facing upward, and everything's covered except the area of the incision. The opening is curved, and it's about the width between my fingertips, so 6 or 7 inches long, and it's opening up over the buttocks muscles on the side of the thigh. The deeper part of that approach involves going between the fibers of the gluteus muscles, that's in the buttocks, and then going through the ligaments in the back of the femur bone coming into the hip joint. This posterior approach involves having to make a vertical split in the ligaments and then get into the hip joint and do the same procedure that the anterior approach does. The thing is, at the end of the case, those ligaments, even if they are sutured together, are not the same as they were before the surgeon went in to do the hip replacement. And some people say that there is a higher risk of dislocation, although it hasn't really been proven to be a much higher dislocation. We're talking about instability of the hip, where maybe a posterolateral approach that I'm talking about has a dislocation rate of 1.5%, maybe 2%, depends on the study you read. It's not a huge number. But the anterior approach, which I'm going to describe sooner, might be between 1 and 1.5% instability. And so that 0.5% or 1% difference might matter to one person out of 100. Because of this difference, traditionally, we've been taught that in the posterolateral approach, you need to have different precautions or protections after the surgery that are inconvenient for a month or more. You're supposed to sleep with a pillow between your legs after the surgery so that you don't cross the legs the wrong way and dislocate. You're supposed to avoid bending over and picking stuff off the floor or breaking 90 degrees of bending with the hip for at least a month and sometimes even 3 months in order to let those ligaments heal in the back of the hip joint. They do, they heal in. As long as there's no problem within 3 months, usually you can do the same motions afterwards as anybody else. And yes, I've operated on a karate instructor who was doing roundhouse kicks and teaching karate after his total hip replacement. So it's not like you can't move normally after the posterior approach to the total hip. But during the initial month post-operatively, there are just some things you can't do because there are rules that need to be followed in order to avoid that issue. The anterior approach is something I taught myself 6 or 7 years ago in order to keep up with the new trend of coming in from the front of the hip instead of the back of the hip. The skin in the front of the hip is different than in the rear. It's a vertical incision just below the point of your hip bone on the front outer corner, and it goes into an area between muscles instead of splitting muscles. So it, in other words, we pull the muscles apart but don't cut across any fibers. And when we get to the hip joint, we also have to cut the ligament, the capsule, the ligament that goes into the hip joint, but it's the front ligaments, and those tend to not allow dislocation as much as the rear ligaments do. So we don't require after the anterior approach that you use a pillow between your legs. We don't limit you from bending your hip as far as you want to after the procedure. The nurses on the 5th floor tell me that the people recover faster from my anterior approaches than from my posterior lateral approaches. So I can say that there's someone who's been observing my initial surgeries and telling me that the patients get better faster. At least that matters in the first 2 weeks. The fact is I've had patients I've operated on one approach on their right hip and the other approach on their left. And there's a split between people who say it was easier with one versus the other. So I wouldn't choose one approach versus the other because of some hype or some exaggeration, but there may be some less pain and some quicker mobility after the anterior approach than the posterior approach. I think the main difference is that you're not restricted for the first month afterwards or even 3 months afterwards from bending over, and you don't have to sleep with a pillow between your leg. The results are really rewarding, and that's why I enjoy this profession, because most people do very well with these procedures. And this is much to the credit of the staff at the hospital. The anesthesia people have come up with great ways of making this less of a barrier to going ahead and relieving your arthritis. The nurses on the floor and the nursing coordinator do an excellent job of staying on top of your case and communicating any issues. One of the things that's necessary and that the coordinator helps to perform is the function of that bridge between the hospital and your home. In other words, there's that first week that really is makes you nervous. You have the procedure, you're going home either the day of or within a day or two after the procedure. You sleep in your own bed, you eat your own food, but what about that pain? What about that physical therapy? What about that mobility? That's where the home care system and the home nursing system and the home physical therapy system needs to be in place. And when those things are in place, it's a lot better. Some people do go to a physical therapy rehabilitation type center or a skilled nursing facility afterwards. Usually that's a person who might live alone, not have their own support group, have to go up 13 steps to get into their house or up to their bedroom, and can't live on one floor for the week afterwards. And usually that's less than a week. Then people go home. Patients stop seeing me usually within 3 months. It's often less. And that's because I usually like to see a person soon afterwards to take care of the staples in the wound. And then a month later to make sure they're making progress. Usually they're just about getting off the cane at that point. And then one more time, close to the 3-month mark, just to make sure that they're done. And most people are. The vast majority are finished at that 3rd post-operative visit and don't need to come back. Some surgeons traditionally have had patients come back every year to get an x-ray of the hip, but I'm not really sure it's necessary. It hasn't changed my management. I figure if somebody's coming back to me with some complaint about the hip, I'll manage it then. But otherwise, I don't require people to come back every year for a repeat x-ray and just to show me how they're doing. That would be unnecessary for both of us to have appointments for people who are just doing well. Return to driving, it all depends. The left hip operations return to driving quicker because you can drive with your right leg. If you have a small sports car and a bucket seat, it's hard to climb in and out of that compared to if you have a sedan and you can just slide over into the car seat and out. But as soon as you can safely operate the vehicle, I generally let people drive after the procedure. If it is the posterior approach, you might sit on a foam pad for a little while so you don't bend past 90 degrees getting in and out of the car. So that's my overall summary of hip replacement, and that's what comes to mind first. If you have any questions or want some more guidance, I'd be happy to fill in some blanks right now.
Dr. Kraushaar, can you tell us a little bit about changes that you need to make at home? Like when you're gonna go back home, do you need to, I don't know, rearrange your furniture or make any changes at home to help you with recovery?
Sure, absolutely. I think the main enemy of any post-surgical case would be loose rugs on the floor. So area rugs, carpeting is good because it's nailed down, but area rugs that you can trip on, you want to avoid that kind of a thing. It's also nice to have something solid to grab onto in case you feel that you need to hold on to something. So next to a toilet, in the bathtub or shower, there might be a need for some handles, and those might be handy to have, at least something solid to grab onto. And it turns out that some people like having those longer than just even after their recovery. So sometimes those modifications help. A bedside commode is nice to have initially afterwards if you can't get to the bathroom fast enough. And having a chair that's a little higher instead of, let's say you have a lazy boy chair that you like to sit in. You're not going to want to sit all the way down inside that lazy boy chair. It's hard to get out of it initially afterwards. It's been rare that patients have asked me for an orthopedic lifter chair, where an electric chair that pushes you out. But on a rare occasion, somebody will mention that. But a nice high seat to sit on with armrests. Armrests are good to have because you can push off of them. No clutter in the hallways would be valuable as well. It would be nice to say a person lives on the first floor for the first week or two afterwards, or at least on the same floor. So if you could live in a bed to bathroom to kitchen and kind of circumstance all on one floor, that's more ideal than having to go up and down the staircase repeatedly. And if you do have to go up and down the staircase repeatedly, it's nice to know that the handrails are truly screwed into the wall properly and not loose or broken.
Mm-hmm. That's interesting. What about the sports? You know, like, can you go back to swimming, golfing, you know, doing regular sports after surgery?
Well, the answer in general is yes. It depends on what. There's cases of there's a baseball player who had his hip replaced and he went back to running competitively, playing baseball, and everybody was amazed until he started having problems with the hip replacement. So going back to pro baseball, running bases and sliding might not be what you want to do with the hip replacement, although I mentioned the karate instructor, and I had a bike rider who broke his hip, and I did a hip replacement because he got hit by a car, broke his hip, and I fixed it. And 6 weeks later, he sent me a picture of himself doing 2 century rides in the same weekend. A century is 100 miles. So he did 200 miles on his bike. Cycling's very good. I think that running and jumping sports, you have to approach with some caution. So basketball, volleyball might not be the greatest thing to play on a hip replacement. Golf is certainly something we look forward to after hip replacements. And we usually say if you're going to play tennis, it might be less stressful to play doubles tennis instead of singles tennis, so as not to have to run all the way across the court. Skiing is very possible after hip replacement, and even swimming. The one challenging stroke for swimming might be the breaststroke because of the frog kick that's done afterwards. But a flutter kick is usually very possible after hip replacement, and it's encouraged. I like swimming as a sport for people who've had hip and knee replacements. They do well with those.
Mm-hmm. Are there any pre-op preparation that you need to have, like something you need to do prior, like lose weight or have a, I don't know, restrictive diet?
Remember, I was talking about complications. I went into a dark place there. And the reason why is because the surgeon always has to be concerned about those things. The heavier you are, the more likely it is you're going to have to face something in that dark place. So people over 300 pounds, really, in my mind, I try never to operate on those. People over 250 pounds really don't like to operate on that either, because it's from the start, the skin just doesn't heal the same. Same thing with smokers. The skin won't heal the same, and the risk of infection is much, much higher, easily 2 to 3 times as high in heavy people and in smokers. Active diabetics. It's okay if a person's taking a little bit of oral medicine for diabetes, but if a person is requiring injections for diabetes, that's no good. So we prefer people to be under 250 pounds if possible, and not be smokers, not be diabetic. That's a more ideal circumstance. Of course, people who fit that description that I just made still need hip replacements sometimes, but the risks go up. I've had patients tell me, okay, doc, I'm coming back in May. I'm going to do from November to May, lose weight, come back 50 pounds lighter. Both of us get very excited, because usually that process of recovering their way they used to be translates into the therapy afterwards, and they do very well with rehabilitation afterwards. So yes, it's better to lose the weight beforehand, not be smoking, try to get control of the sugars. Those things all matter a lot. They matter a lot.
And if you were a smoker, like how long do you need to stop before surgery? A couple of months, a couple of weeks?
I don't know that there's any science to exactly how long it is, but a week is barely adequate. And I have trouble believing that a person who's only stopped smoking for a week has really stopped smoking. So if they start smoking during the postoperative period, they're really inviting problems with wound healing, which brings me to blood thinners. Patients who take blood thinners, let's say you're on Eliquis or even aspirin beforehand, we usually try to get you off of blood thinners before the procedure because it's better not to have thin blood coming into the procedure. But we do like to use blood thinners after the procedure. Blood thinners have changed. People used to use Coumadin, which is a very strong blood thinner, and we almost never use Coumadin or warfarin anymore after a hip replacement or knee replacement. Instead, there were medicines that we still use sometimes. Eliquis is an oral medicine, and there's a couple of other oral opportunities as well as injected opportunities that people can use for medication, like Lovenox, and too much, and they cause oozing of the wounds. Aspirin has always been in the background. Some people were using aspirin as a blood thinner for years before the recent trend. But recently, the trend has come back to using aspirin much more. And the reason why is there's less oozing and less wound healing complication issues with aspirin than there is with all that other blood thinning stuff, heparin type products, or other stuff that affects your platelets differently than aspirin, or your clotting factors differently than aspirin. So we try to get people on aspirin, 81 milligrams, once or twice a day. But we have to make a decision called stratified risk, which is that if you're a smoker, if you have clotting issues, we need to know these things ahead of time, because every decision on every patient about blood thinning is made independently for you, for what we think is best for you. And that's not a perfect science. That's just a really educated guess as to, well, I think this person will do well on aspirin, unless we really know that a person needs to be on blood thinners anyway. For example, if you have a cardiac stent and you're taking a blood thinner, we just put you back on that, and that's good enough. You have to be on it anyway, so we use that. Wound oozing and wound healing is usually related to those factors, as well as the smoking issues and immune issues, but otherwise most people heal very well, and with aspirin, the wound healing is usually very good.
How long does the surgery usually take?
It depends. We can get a total hip replacement in a 120-pound female who's generally healthy in 45 minutes to an hour. We call that skin-to-skin time. But sometimes it can be an hour and a half for some procedures, or even 2 hours, depending on what bony issues that we encounter or what anatomy we encounter as well. One of the things about the anterior hip replacement, at least in my hands, is that it takes a little longer than the posterior hip replacement. So if a person needs to be the kind that their medical doctor tells me we need to do the shorter procedure, I'll do the posterior approach, which usually I'm done within an hour and a half or less. And we don't rush. We do it nice and steadily and nice and smoothly, but taking a good time, doing a nice meticulous approach, making sure everything looks nice before closing, can take about an hour and a half usually. Anterior hips can take me between an hour and a half and 2 hours, mostly because I use a special table that Montefiore has called the HANA table, and some of the operations of the equipment take a little bit longer to set up. So the steps are a little bit longer during an anterior approach than the posterior approach in my hands, although the more that we do, the faster that we get with even that approach. So I have done those in an hour as well, without rushing. It just is something that if it goes very, very smoothly, it can be an hour. So that gives you the idea of the time range for the procedure. And I usually try not to promise a time. I just say as long as it takes to do a good job.
Are there any exercises that you can do to help you heal faster and make your hips stronger after surgery?
It's a good question. I call it prehabilitation, and I do like people to be in good shape going into the procedure. The better musculature you have around your hip joint beforehand, the faster you'll recover. And the more flexible you are coming into the procedure also, the better it is afterwards. So flexibility and strength are not exclusive of each other. They actually work together. So if a person goes on a yoga or a Pilates type of a program, teaches them really good balance. I like that coming into joint replacement surgery if possible. If you can't get physical therapy covered by insurance, then at least a home exercise program does help. But that would be good. After the procedure and before the procedure, I happen to like treadmill. I happen to like elliptical trainer and bicycle better than treadmill for a lot of patients, because they don't have to stand on a treadmill and fall off the treadmill. They can stay on their seat on the bicycle, or they can use the elliptical trainer and hold onto the side rails. That's not something you do immediately afterwards, but in the intermediate recovery stage between the second and third months, those are good devices. Later on, a treadmill is useful.
And do you have to go to physical therapy for that, or is that something that you can do at home unsupervised?
It depends on who you are and what kind of exercise that you do. I know some people in their 80s who go for bicycle rides every day, and they're very active. And I know some people in their 50s who seldom get off the couch. So it really depends on your starting point, your exercise history. If you know how to exercise ahead of time, it's good, but some people just don't live that way. So if you don't know what you're doing, it's nice to get a little bit of exercise beforehand with a physical therapist. And there's some truth to the idea that if you learn how to do the exercises before the procedure, then you'll have a muscle memory afterwards, and you'll be able to get back into it quicker than if you first have to learn those exercises in the fresh post-operative state.
Great. I think you have answered all of my questions. I don't know if any of the attendees has any questions. Please go ahead and write them in the chat box or use the Q&A. And, you know, other than that, I know that you're in between surgeries and running a little bit, so I will let you go because you need some break too. So are there any questions that you would like to ask the doctor? Let's give it a minute to see. But I think this has been so comprehensive. I would love to see your slides later on to add to the presentation, because then, but you know, you were so visual in the way that you were explaining everything. It was great. I could totally picture in my head what was happening during the surgery. So that was a great explanation. Thank you so much. And thank you for taking the time between surgeries to be here with us today.
It's my pleasure, and anybody seeing this recording in the future, if they wish to get in touch with me and speak about this or make an appointment, they're welcome to do so. You can provide my email address if you wish with this presentation, and I'm happy to answer any questions I can.
Great, I will then. So I'm gonna let you go, and thank you so much again for spending your time with us. And I'll see you soon.
My pleasure.
And thank you to our attendees for joining us today. Don't forget that we have these chats every single Thursday, 12 p.m. So we have an upcoming, well, we're done for this year because now the next 2 Thursdays are the holidays, but we're gonna be back in January with Treat Your Children with Care, which is going to be a behavioral approach to treat children with behavioral issues. We're going to be talking about diabetes, cancer support, and lots of other topics of interest to everybody. So happy holidays, and thank you for being with us and supporting our Community Chats program. Bye-bye.